of the lesion with non-enhancing fungal mass central component of the lesion. And for the same patient, axial T1 weighted image post contrast shows peripheral enhancement of the lesion, non-enhancing fungal mass with underlying peripheral enhancement of meningeal layer. Mass effect is noted in terms of effacement of frontal horns of lateral ventricle and midline shift. Evidence of intraorbital extension to the left side. This is the right orbital cavity. And CT scan for the same patient shows the lesion appears as hypertense compared to adjacent brain parenchyma and more or less similar to adjacent punicalvarian, denoting associated calcification. Case example number 4, male patient 35 years old, presented by massive right hand mycetoma, 4 years duration. Coronal T2 weighted images for the patient shows the lesion extending from subcutaneous plane, assuming predominant bright signal intensity with low signal intensity fibrous matrix, and fungal grains assuming low signal intensity and multiple innumerable micro abscesses. Low signal intensity foci represents multiple innumerable micro abscesses and the fungal grains, as we see, infiltrating the underlying soft tissue musculatures of the senile group of the hand with large intraosseous cavitary lesion assuming central low signal intensity fungal mass, peripheral bright signal intensity granulomatous tissue, and outer layer of fibrous matrix. Intraosseous large cavitary lesion. And axial T1 weighted images for the same patient shows the extent of infiltration of the lesion, extend from the subcutaneous brain to infiltrate the underlying mitochondrial structure and extending deeply to underlying bone. Evidence of bone marrow infiltration is noted here. If compared this bone to adjacent normal bone, shows the obliteration of normal fat signal intensity of bone at T1 weighted images, denoting bone marrow infiltration with intraosseous extension and large intraosseous cavitary lesion. Post enhancement shows intense enhancement of the lesion, denoting vascularity and the vascular component of the lesion. The granulous tissue and the fibrous matrix enhanced, but the fungal grains doesn't enhance. And we can see the sinus tract here containing fungal grains. This is the fungal grains inside the sinus tract. And we can see the extent of the lesion by post-contrast T1 weighted images. With intraosseous cavitation containing fungal mass. Case example number 5, female patient 35 years old, presented by massive foot actinomycetoma, 4 years duration. X-ray shows relative hyperdense mass center at the hind foot with evidence of bone sclerosis at the calcaneus and multiple innumerable intraosseous microabscesses. Sagittal stere images for the same patient shows an ill-defined infiltrating soft tissue lesion extending from subcutaneous brain, extending deeply to infiltrate underlying mitochondrial structures with evidence of bone marrow filtration. Bone marrow edema is noted as a talus bone with infiltration of calcaneus, shows multiple innumerable microabscesses containing fungal grains assuming low signal intensity as we see within the calcaneus bone. Bone marrow infiltration is also seen at other tarsal bones with a reactive joint effusion. The lesion appears infiltrating the Achilles tendon with consequent insertion tendinosis of the Achilles tendon and extending at the subcutaneous plane superficial to Achilles tendon as we see. Bone marrow edema is noted as the distal end of the fibula, and the lesion shows characteristic pattern of mycetoma of bright signal intensity, granulomatous tissue, fibrous matrix, and multiple innumerable low signal intensity foci, less than 1 centimeter of microabscesses. Skin sinus tract is noted here. And axial MRI T2 weighted image shows the extent of the lesion extending from the subcutaneous plane from the medial and lateral aspect of the foot with infiltration of bony osteostructures structures of the tarsal bone, mainly the calcaneus bone. We can clearly see the infiltration of the lesion and its extent, and this is a sinus tract. Reactive sclerosis is noted here at the calcaneus bone, assuming relative low signal intensity compared to adjacent normal bone. And the T1 weighted images for the same patient, coronal images, shows iso-intense signal intensity of the lesion with infiltration of bone. Post-contrast study shows enhancement of the lesion with non-enhancing fungal grains, assuming low signal intensity. Conclusion: MRI is a useful imaging technique. Mycetoma has a characteristic pattern. Extension of mycetoma can be determined by MRI. MRI is important for planning surgical intervention. Recommendation is MRI is recommended for diagnosis of mycetoma and determine its spread and extent by mycetoma skin muscle bone classification. Further research is needed to determine the prognostic feature based on mycetoma skin muscle bone classification. Thank you.
Thank you for a really interesting presentation. So I think we're going to try and go to Saudi Arabia now by Skype. We failed. Right, okay. I'm thinking on my feet here. Could we have both speakers up at the front and then we can take some questions from the audience? Okay, do we have any questions?
Bismillah ar-Rahman ar-Rahim. Thanks for both speakers. I would like just to have a comment at the beginning, and any one of them can answer the question at the end. The comment is that obviously ultrasound has a quick gives a quick response to a complaint of a patient and a cheap investigation that can reach a diagnosis. MRI is good at describing the geography of the lesion if surgery is contemplated. But we still, as Professor Sheikh Mahjoub said yesterday, we still need to know a lot about the biochemistry and epidemiology of the lesion, so that during treatment or before treatment we can help the patient. I'm just asking a question: if PET CT in the future is give that opportunity, because monitoring glucose or monitoring fluoride or monitoring material within the lesion will be an indicator of the biochemical and immunological changes that take place. If any one of the speakers has an idea to tell us about this future development. I think these two techniques are exhausted now for giving any more information.
I think ultrasound is cost effective compared to other imaging modalities. And I don't know the expense of PET CT or but as I know, it is the machine itself is very expensive. Right? So these patients of mycetoma are poor patients who is going to and most of these investigations are funded by these patients, so they cannot afford. And MRI, I think it is also it is cost effective. It is not cost effective in diagnosing mycetoma. So implementation of new technique like PET, this will be very expensive for such patients. If there is a fund, I think why we don't proceed to do PET for these patients.
The application of PET CT is mainly in oncology and the detection of metastasis or local infiltrations, which can be clearly seen by conventional modalities like CT or MRI or even ultrasound. So the PET CT is may be helpful for early detection of bone marrow infiltration, may be helpful for detect lymph nodal spread, which can not be clinically noted or by conventional modalities like CT or MRI. So it's I think it's an application for detect of its lymph nodal spread or early infiltration of bone, which may be can't detected by MRI study.
Thank you very much. I think the challenge in mycetoma is hidden in the treatment, because it can be diagnosed by nurses and health assistants and by patients themselves. The challenges are the extent and the treatment. And I think instead of directing all the efforts and money towards diagnosing what has been already diagnosed by the patient, is to direct efforts towards eradication and treatment. Thank you.
Do the speakers want to respond to that?
Only, Dr. Al-Sami', maybe when you want to do surgery at when the lesion is adjacent to important organs, it's very deceiving from the outside sometimes. I agree with you, I might not make it a regular, a daily investigation, but certainly with some patients it will help you to limit before you go in with your knife. Thank you.
Sometimes the discharging grains, this is diagnosed by the patient or by anyone, okay, the site of this sinus is very deceiving, because mycetoma is going to spread along the facial plane. And a month ago, I saw a patient with discharging sinus at the lower leg, but the grains found to be just at the knee, just at the level of the knee. So if you remove the grains at the site of the sinus, definitely you are going to have a recurrence, or already the lesion is there. So just you excise a limited area and you leave it. So the extent of the disease is one of the imaging modality is going to be one of, you can use MRI or ultrasound to see the geography of the lesion.
Usually the imaging modalities is not for diagnosis but to confirm and choose extent and the planning for management, not for diagnosis. Maybe some cases already diagnosed, but we need to planning for management, either medical, surgical, extent, as this is the evidence of bone marrow filtration, bone cavitation, and we need this and this stage need imaging modalities to planning for the management and also early diagnosis before detection by the nurse or the patient itself. Early diagnosis.
I beg to differ with my head department, Mr. Bassemi. It's not an easy to diagnose mycetoma, as you can see. Sometimes it's very difficult because you have the important thing how to diagnose mycetoma properly to plan the treatment for these patients. Without this, you cannot treat these patients. If you can go to remove the mass, it will recur in few months' time. Recurrence means recurrence and recurrence. Very difficult to treat this patient eventually. So the first step is to have a proper diagnosis of mycetoma. Sometimes you go to the level of molecular biology to diagnose a case of mycetoma at this site. Some of the patients, they don't respond to medical treatment because they are different organisms. So it's very important to have a proper diagnostic procedure for this patient. So to plan the surgical treatment and to plan the medical treatment. We start by medical and then the surgical treatment. If you are going to have just chop them out, it will recur in few months' time. Yesterday we presented cases, miserable cases, because the problem was the diagnosis, improper surgical treatment, and they came with recurrence and difficult to treat. We saw a patient yesterday just like a malignant disease. Local recurrence spread by the blood, by the lymphatics along the facial planes, and massive local destruction. So as a surgeon, myself, still I have to look for a proper diagnosis before going and cut it by a knife. Thank you.
First of all, I would like to thank both of our colleagues, Rai and Shami, for their nice presentation. From the previous sessions yesterday and today, it seems to be we are dealing with the advanced, horrible lesions of mycetoma. Concerning the MRI and ultrasound today, I don't think there is a place for the MRI for early detection of the lesion. But the ultrasound seems to be, will be very useful in early detection of the lesion in the targeted area. And we are talking about mycetoma in Sudan, not in Khartoum. Our awareness about mycetoma in the area of invasion. But all sessions now tackling the advanced, horrible, destructive, worrying lesion. And what I remember yesterday, the comment of Professor Muhammadani. After the session, and I have got worried. Now, if I am preferred to choose between cancer and mycetoma, I will choose cancer. And he's wise enough in this because mycetoma, it behaves like tsunami inside the tissues. The question is that, is there any place for the portable devices or apparatus to be exported to the areas concerned, Mantiqat al-Nil al-Abyad and so, for early detection and differentiation between the different lesions in the tissues of mycetoma before it makes this horrible situation in the tissues? Thank you.
Just want to ask one question. We know that here MRI has given good results showing the local spread of the disease. Were there any studies regarding the regional lymph nodes? Can we assess them through ultrasonography, MRI, or Professor Ahmed Fahal, sampling of the regional lymph nodes?
Okay.
Thanks.
Concerning patients, all these patients actually, or most of them coming from peripheral areas in rural areas, and I think it is better to send the service there at their locations. So a portable ultrasound of high frequency, it is available in the market, and it can be done at the field. Okay, but it's very expensive portable ultrasound machine with high frequency facility. So, but it can be funded for all these patients, and the ultrasound can be done at the site of the presence of mycetoma. Regional lymph nodes also can be assessed by ultrasound, and I think it is cost effective to be assessed by ultrasound as compared to MRI, because MRI we target the area of the lesion, and then if we are going to assess the regional lymph nodes, we should scan the patient again, so this will double the cost. But by ultrasound we can just jump by the probe and scan the regional lymph nodes, so we can see if there is involvement or not. And also can be.
In your experience, did you see lymph nodes with ultrasound, the glands inside?
Yes, I saw lymph nodes with ultrasound on ultrasound, but I couldn't detect any grains in these regional lymph nodes. Just maybe tender lymph nodes, secondary bacterial infection. This will cause regional lymphadenitis.
Are we going to go next door to a question? No, answer their question.
Thank you very much. Actually, I am not denying the fact that imaging is important, but unfortunately, the two presentations they showed that ultrasound and imaging are feasible, but actually the fact which you are looking for, to what type of patients, should we do it as a routine? I think it's a very important question. Any patient with a suspected mycetoma, should he have an ultrasound or an MRI or a beta? Now we are moving further. I think the question is that how does the investigation help in the management, and what type of patient needs specific investigation? Because if you want to come, yes, from what he heard now, beautiful pictures about the MRI, about the ultrasound, but we are forgetting the health economy of the disease, and we are forgetting that those patients cannot avail themselves for such investigations. Should we send all the patients to MR center here for MRIs and ultrasound? Or what are the indications for ultrasound in mycetoma? What are the indications for MRI in mycetoma patient? Thank you very much.
That was the same question as
I'm trying to protect my students, actually, because I'm sure next exam, when you ask them, what are you going to do for this patient, they will tell you MRI. We cannot deny the role of MRI and CT in the extent of the disease. But I think we should not send wrong message to registrars, medical students, that when you see a patient with MRI, right big toe, you should go for MRI. The extent of the disease should be diagnosed by any means if needed. But I think the serology and direct microscopy and ultrasound, let us say, how much should diagnose? The next research. When do you need to do MRI and CT scan? Thank you.
Okay. The main advantage of MRI for problematic cases for diagnosis, and problematic cases for recurrence, problematic cases for planning for mainly surgical management or surgical treatment. So the early the ultrasound is easily economic and can be done, and in every places, every multiple ultrasound can be done. So MRI we can limit it for problematic cases for diagnosis, problematic cases for extension, problematic cases or before surgical management to see the extension of the lesion. Okay.
Okay. Yes, excuse me. I'm doing my master's in public health in the University of Medical Sciences and Technology. And thank you very much for your beautiful presentations. I just have one question, that we use this diagnosis, we have two types, clinical and therapeutic diagnosis. As Dr. Raya has said, that is there any available technique like IV that we can inject it directly in the lesions, and can it be useful for the treatment instead of going for amputation? Amputation is the treatment for the massive cases, but can there be like a CT scan injection or injecting material through ultrasound and it can prevent the disease from progressing? Can it be the next research or something of that sort?
Yes. I will come to the previous question. Ultrasound is going to be done for planning, as illustrated in the lecture, for planning surgical management, extent of the disease, and differentiation from other similar conditions. Diagnosis may be straightforward clinically. Concerning injection of a safe material into the lesion instead of amputation for patients, this is just we are waiting for a material which will be safe to the tissues and harmful to the grains. So who is going to create this material to be injected using ultrasound guidance into the lesion? Instead of amputation, we just inject a material inside the lesion to kill these grains and to be safe to the tissues. So we are waiting. What material? Yes. We are ready to be to use it, yes, and to inject it inside the lesion.
Thank you for this opportunity again. Actually, I'm asking about practical point of view, the question of our teacher, Professor Iman, how I can handle patient who presented with swelling to us. Shall I proceed for PCR? Shall I proceed for ultrasound? Or shall I proceed for MRI? We need a practical point of view for this condition, please. Second question, is the hypervascularity of the mycetoma mass can be used for further treatment and control for prevention of advancement of mycetoma progression for further research or not? Thank you.
I would like to respond to the surgeons here. Yeah, if you're going to have a diagnosis for ultrasound, is a long list of investigations. X-ray appearance in early lesion, it is not very useful. It will be a normal X-ray appearance. You may see a soft tissue mass. A long list of differential diagnoses. If you have a clear-cut diagnosis, you need to remove that mass, send it to histopathology, send it to the lab for culture identification. Nowadays, even the culture identification is not enough to reach a diagnosis for mycetoma infection. You go for a PCR, other molecular diagnosis to reach a diagnosis for these cases. The response of this patient to medical treatment is different. Many of the patients with the black grains, they don't respond to medical treatment because they are different organisms. The other problem that the ultrasound is important to reach a diagnosis for two reasons. You have to see the grains, the cavities, the fluids to diagnose mycetoma at this site. Through the ultrasound, aspiration can take place and you can send it for cytology, an important diagnostic procedure at this site. So ultrasound is important for the diagnosis of the mycetoma. You cannot rely on simple X-ray to diagnose mycetoma in this patient. You cannot rely on a simple clinical diagnosis to reach a diagnosis, because the response is different, the treatment is different. Not all the patients are going to respond to ketoconazole. You are not going to remove the mass and send it to histopathology. It is expensive, it is invasive. Ultrasound is a simple outpatient procedure. It is non-invasive and it is cost-effective. When you compare it to other modalities like excisional biopsy and surgical biopsy and then these things. MRI is important to reach a diagnosis and to reach the extension of the disease. You plan the treatment. Shall we start by medical treatment first for 6 months and then to localize the disease, and then you go for surgical excision after that? So this is the importance of MRI and the ultrasound diagnosis of this. It is, by any means, it is cost effective when compared with other modalities. The only tool nowadays available is surgical excision and histopathology. But sometimes you see cases with advanced disease, surgical excision will be impossible in this patient unless you do an amputation of this. We have to start with medical treatment first, localize the disease, and then you go for surgical excision after that. For the medical student or for the registrar, still the ultrasound is important diagnostic tool. First, to reach a diagnosis. You can differentiate between the actino and EU mycetoma in these patients. You can know how extensive the disease is. And after that, I am a surgeon, I can take the patient to surgery, but recurrence is 90% in these cases without proper medical treatment in these patients. So I think we have to be very systematic. We have a rule for it. In the center you have a guideline, history, examination, ultrasound. If the bone is not, the bone is always late pre-manifestation of the disease. By the time you have a bone lesion, you miss the bone. Really difficult to treat after that. We would like to see this patient early. With these ultrasound things, you can localize the problem, you can plan your surgical excisions, you plan your incisions, and that is important things at this site. So I still go for the ultrasound as an important diagnostic tool even before the X-ray. X-ray will show you nothing in the early lesions, and it may be very deceiving. So by the CT scan, you can see the changes in the bone before the bone seen in the plain X-ray at these patients. Thank you.
Just an extension of what Professor Fahal said, and in response to the question of Badruddin about portability of a machine for the remote areas. Obviously, there are a lot of portable machines. Still, they are expensive for rural areas, $8,000 to $10,000. But luckily, recently, a pocket-size ultrasound machine has been manufactured at experimental level in East Virginia. Professor called Vitov published a book about 4 or 5 weeks ago about the pictures coming out from that machine, and in 2 or 3 years' time, it will go into the market. It has the capability also of sending online images to somebody like Rayah, so that from Hasahisa or from Managil, a picture can be sent online immediately, and Rayah can give his comment about whether this is an abscess or mycetoma. So and that's the price of that machine is about $800 to $1,000. So one would expect that will be a good help for future early diagnosis of mycetoma. Yes.
For the question about follow-up of patients using Doppler ultrasound, actually we did a work in Doppler ultrasound of mycetoma, and this is under publication. But also we may use this data to follow up patients in assessing the Doppler flow of mycetomatous lesion. So after giving medical treatment, so the same group can be scanned again to see the effect of treatment.
I think, yeah, I fully agree with what Ahmed said about the role of ultrasound in diagnosis. It helps to, in addition to the other tools that you have, For the MRI, I'm not so sure. Definitely, I think after a patient has received medical treatment, you plan your surgery. You would like to know where you need to cut. I think that's definitely the case. Doing an MRI early during the diagnostic process, I'm not so sure to what extent it really adds to the ultrasound. And I think that could be a subject of study, doing an early MRI and to try to find out to what extent that influences your management, as you already suggested. Do you go for medical treatment first, or do you go to surgery first, or a combination of the two?
Salam. I think in such conferences, as much as we are presenting new results, we would like also to send out messages. And so now we are at a debatable issue. I can appreciate what Ahmed is saying, where facilities are available and we can do them all. When Abdul Sami'. And I also appreciate what Abdul Sami' and Babikar and Badruddin have said, that these facilities are not available all over the country. They are not affordable in all the country. So we have medical students here, we have registrars who want to take away a message. We have a disease now that is reported from all parts of our country. I think we should come, I always like compromises. I think we can need, although there is no compromise in science, obviously you will examine your patient clinically. I will not throw away the plain X-ray. Still, there is room for it. And maybe we will go for ultrasound. And we leave the MRI for the advanced cases we will see in the brain like tomorrow, or what has been reported from your country when they talked about the MRI. They had lesions here on the chest, and before they wanted to go in, they wanted to know. These are very important structures around here, or in the back, or in the groin, and so on. So, and you have seen mycetoma at different sites. So I think it will be appropriate to leave the MRI for these advanced infections at important structures. But I think the medical issue and the research should keep it in mind as an investigation to be used when needed. But start your usual investigations, and will not be content with the words of the patient, or a hurried clinical examination, or the quality of the X-rays. This gentleman has very beautiful X-rays in the Zaytuna, the ones we saw. These are beautiful and very clear. If you have that quality, you can see. But if you don't, still take it. You must have the radiologist's comments, not to be read by the doctor himself, and so on. I think with these precautions, we will benefit our patients. But what Ahmed has said is very serious, the rate of recurrence. So now, when we come to talk about control and therapy, we will try to avoid this high rate of recurrence by early reporting. But people should not think that an opening sinus is the beginning and the end of that mycetoma. Thank you very much.
Sorry, again, regarding the regional lymph node, I was just asking about the screening of the regional lymph node, not an enlarged lymph node for infection or whatever reason that. Second question is ultrasonography is very helpful. Could we know the false positive and false negative and the operator dependency? You know what I'm talking about. In the market, we have a lot of people, they do ultrasonography and it's not reliable. Could you comment on that, please?
Actually, we didn't do did screen for lymph nodes. Okay, but ultrasound needs a special training for the radiologist in musculoskeletal ultrasound. This is a superficial body structure. You have to know solid knowledge of the anatomy of the body surface, muscle, how they look like, and how pockets look like, and similar conditions can be differentiated. Sometimes, as in every clinical condition, you may find difficulty to reach a solid diagnosis of mycetoma. Maybe some difficult cases, but similar cases may be straightforward, but some difficulties may be faced with the operator.
Good morning. I would like to congratulate both of the speakers about their rich knowledge and material. I found this debate, it looks like what is going in the breast. When one of the clinicians told me why I go for ultrasound for breast and I'm holding the mass in my hand. We have to go with the science, and we have to go forward for ultrasound and MRI. But I don't know if there is any studies, controlled studies, to compare between MRI and X-ray, plain X-ray of the results of mycetoma. Is there any controlled? If there is no, we have to design for one. And I think we have to go forward to use these utilities. And we have our health insurance, and things are developing now. So we cannot stop the development of science and the development and our quality of management to the patient because of the cost. Thank you.
Every imaging modality has a specific pattern and characters and advantage. X-ray has its quality for detection of bone lesions and soft tissue lesion. If high dense soft tissue lesion, vague soft tissue lesion in X-ray, we can differentiate it pattern of the lesion or infiltration, and can't characterize this lesion in soft tissue. In X-ray, we can see bone structure, bone sclerosis, bone cavitation. Every image modality has its limitation and the data. For X-ray, give me data. Ultrasound give data for soft tissue extension, characterization, echo pattern, calcifications. This data give me some informations, but it's still bone can't scanned by ultrasound. Deep extension can't scanned by ultrasound. Like in the case example number 1, we have extension deep to pelvic cavity can't scanned by ultrasound. So every modality has its advantage and limitation. Ultrasound has limitation in bone deep structures. X-ray has a limitation of characterization of tissue. MRI has more advantage in characterization of tissue and extension and the bone marrow infiltration early, even in bone marrow edema, which is presented as an early bone marrow infiltration. This is the advantage of MRI to show the limitation of other modalities like ultrasound or X-ray. MRI can't excluding X-ray or ultrasound for primary diagnosis because ultrasound is cheap and can be available in any place. But some lesions like deep extension and early bone marrow infiltration can't be detected by ultrasound, and maybe affect the planning for management. So my suggestion to start step by step, not for jumping on MRI or for jumping to advanced technique, starting by less invasive or less cost modality and available modality like ultrasound. Ultrasound give us data for soft tissue lesion, and maybe added with X-ray to show bone infiltration, and starting for like Prof talked, start to the treatment if there is problematic cases for recurrence post-operative recurrence, planning for surgical management, suspected deep extension, like this is for example number 1 cases, intrapelvic extension, brain in Mycetoma. At these situations, we can jumping only for MRI. Okay, thank you.
Have a question in the other room you can go to? No, it's not there. Okay, I'd like to Professor Fahal has a comment.
Yes, before we finish, I would like to express my sincere thanks and gratitude to Dr. Mahmoud and his institute for offering our patient a free MRI for those who cannot pay for it. Well, I think this is a very important step in the advancement of the management of these patients. The ultrasound is important for post-operative. And ultrasound again is important for follow-up of these patients. If the patient comes with recurrence, you are not sure. You have to do a surgical excision or take a deep biopsy for culture and for grain identification. Ultrasound can simply tell us, is this a grain or is this a granuloma or is this a hematoma or whatever. So I think we have to go forward. We should never go back. We should not compromise the management of our patients. Cost is important, but the compromise of management means recurrence. Recurrence means amputation in this country. Thank you very much.
Okay, so both speakers can take a well-earned rest and go and get a coffee. Thanks for everyone for the lively discussion. It was a great session.